All right. So I guess we'll start with the interns. I'll flip the coin and we can start with Ziad. You want to share your screen?
Can everyone see that okay?
Yeah.
Okay, awesome. Thank you. I'm Ziad. I'm one of the interns. I've been working with Dr. Kellner on this project for vagal nerve stimulation and enhanced stroke recovery. I think most people are familiar with this project involving the VALOR and the GRASP registries. But briefly, the goal here is to look at pairing vagal nerve stimulation therapy with physical rehabilitation for stroke recovery. We're looking at adults with chronic ischemic stroke who have a residual upper extremity weakness. In Mount Sinai Health System, we have over 1,000 of these annually. So the study involves implanting the Vivistim device, which is shown here in the top right, and then doing vagal nerve stimulation with physical therapy for a total of a year. 6 weeks of those are inpatient. The original FDA trial that got the approval for this therapy was actually only 12 weeks, so we're doing an extended rehabilitation period. We're also looking at many more metrics than the prior study had, including Fugl-Myers, as well as a variety of cognitive batteries and surgical adverse events, in addition to the NIHSS and MRS scores. We're looking at the baseline scores as well as every 3 months and then yearly after the first year. So currently we have 16 patients who have been implanted with the stimulators and 10 of whom have at least 6 months of follow-up. I'm looking at that data now. But briefly, we have seen compared to the initial study, which showed about a 6-point improvement in Fugl-Myers scores for the upper extremity with the paired vagal nerve and PT therapy. We're seeing about double that improvement in our cohort with the longer-term physical therapy. So it's very promising in terms of how the advanced recovery can improve with longer physical therapy, and hopefully we'll have about a year's worth of data to submit by the end of this year.
Thanks, Ziad. Does anyone have any questions or comments about his plan? Great. Okay, we'll move on to Mike Early.
Screen. My project will be looking at evaluating outcomes in patients with giant intracranial meningiomas undergoing preoperative cerebral angiography, specifically the impact of tumor location, vascular involvement, and embolization. And I'm going to be working on this project with Dr. Shrivastava. Studies have shown that compared to smaller meningiomas, giant intracranial meningiomas have lower gross total resection rates, higher recurrence rates, and increased post-op complications like ICH and infections. I found just two studies looking at pre-op embolization, and one study found that no embolization led to more complications in giant intracranial meningiomas. And then the other one found that pre-op embolization led to gross total resection. So I'm interested in looking at other outcome variables. So my population of interest are patients who underwent surgical treatment and specifically pre-op cerebral angiography for primary meningioma tumors greater than or equal to 5 centimeters, as this was the most reported cutoff in the literature between 2016 and 2024. And I'd be looking at factors influencing surgical outcomes. And then this would be a retrospective single institution cohort study using the preoperative meningioma embolization series, which our group has published on before. The dependent variables I'm looking at are, in addition to resection status, are progression-free survival, recurrence, Simpson grade, Karnofsky performance status, and complications. The current status of my project is data is still currently in the data collection, and I'm still parsing through the database to figure out what I need to collect still and how to organize the data.
Okay, let's move up the chain. Ansley, do you want to go next?
Can everybody see? Everyone can see, right?
Yeah.
Okay, cool. So for my research update, I'm presenting a continuation of a project that I started at UCLA, which explores treatment characteristics for atypical meningiomas. So as of yet, atypicals don't have a standardized treatment paradigm. So at UCLA, I became pretty interested in looking at adjuvant radiotherapy post-surgically. We found in that cohort a statistically significant progression-free survival outcome between 2 and 5 years. So moving on at Mount Sinai, obviously we have a very robust patient population of these individuals. So we finally got approval to collaborate multi-institutionally and began data collecting. You can see to the right of my screen our multi-institutional data. So there's like Sinai and UCLA all together there. And preliminarily, we see the same results redemonstrated, but now with the larger cohort, we also see improved overall survival as well. So it's really promising. And we're in the write-up phase now and getting the official signature agreement contract between the like approval offices for collaboration. So we should be finished writing that up within the next few weeks and be able to publish.
I think my one comment is I heard that there's an ongoing clinical trial that's comparing these. So I think try to get this out before that comes out.
Yeah, for sure. Thank you.
Dan, do you want to go next?
Hey everyone. Hey, I'm Dan. I'm PGY2. So basically the things I've been working on are all under the sort of topic of electrophysiology. So I'm just presenting a couple of things I've been working on with that. The first thing on the left panel is the intracranial electrophysiology of meditation. So this is work that I've been doing with Dr. Panov, essentially looking at what changes in brain electrophysiology do we see intracranially with patients undergoing meditation. And the first thing was a paper that we published in Epilepsy and Behavior, demonstrating that there are unique changes that occur in epileptic versus non-epileptic mesial temporal lobe during meditation. And this is in patients undergoing stereo EEG. We have another paper that as a co-author on that we have accepted to PNAS, demonstrating the same thing basically in patients with RNS, in which we can look at longer term effects of meditation because patients are implanted with these devices permanently and we can record over several weeks to months. So I'm working on looking at the longitudinal effects of meditation on mesial temporal lobe electrophysiology. The next thing is with Dr. Kellner looking at subgaleal EEG. So essentially looking at EEG not just as a tool to detect seizures, but really as a vital sign of the brain, and looking at can we detect changes such as alpha delta ratio, which we see in subarachnoid hemorrhage? Can we use similar markers to track patients with things like intracerebral hemorrhage? And so this is preliminary results from patients with intracerebral hemorrhage undergoing MIS evacuation, demonstrating that we see essentially the same thing as with subarachnoid hemorrhage with delayed cerebral ischemia, which is a decrease in alpha delta ratio on the side of hemorrhhage. And so essentially, subgaleal EEG could potentially be a biomarker of intracerebral hemorrhage in patients at risk or at risk of worsening. And then this is a figure actually done by Ansley. So demonstrating sort of the conceptually subgaleal EEG versus scalp EEG versus electrocorticography as different modalities of invasiveness for brain monitoring. And then the last thing working with Dr. Kopel is essentially toward the idea of adaptive deep brain stimulation. So in patients implanted with DBS for movement disorders, one very high goal of the field is to not just deliver stimulation, but to, in the same sense as brain-computer interface, detect biomarkers of symptoms and modulate stimulation based on those biomarkers. And so one particular thing that I've been looking at is in patients with Parkinson's, they can also be impacted by dystonia or locking up of a muscle of part of the body. And so essentially we found that frequency range between 4 and 10 hertz in the theta alpha range apparently is unique in patients with Parkinson's when they're affected by dystonia. And so this is something that we're writing up, hopefully submitting to movement disorders clinical practice pretty soon. So, and for the stroke work, we're still recruiting more patients with Dr. Kellner. So it's basically the status of the stuff I'm working on.
Thanks, Dan. Let's move on to Emily next.
My screen?
Looks good.
Okay, great. So I'm going to talk about a project that I'm working on for the year with Dr. Chivastava. This is looking at in order to better understand hydrocephalus in patients that are treated with for vestibular schwannomas. This is a retrospective database we have now of patients who have undergone surgical resection, just radiotherapy, as well as both modalities, and also patients who have been observed with no treatment. The inspiration for this project was that preoperative hydrocephalus is not, there isn't a consensus on what those exact, what the exact incidence is. It ranges from, 15% all the way up into the 40s. And there's even less known about post-op hydrocephalus. And so what I'm doing in this project is retrospectively looking at all of the vestibular schwannoma patients that we have over 2009 to 2020 period, and dividing them up into these cohorts that you can see here. The highest number of patients is in the observation only, as you can see, but we have a good sizable population for each of them. And then looking at important clinical factors such as tumor volume, fourth ventricular effacement, to better understand the patterns and trends of pre-op and post-operative hydrocephalus. Some of these findings, you can see this table has a lot of numbers, so I'll just summarize here. Some of these findings are not super surprising considering what we see clinically. Patients who got radiotherapy tend to be older, they tend to be have score higher on the frailty indices. And the patients who have both modalities have higher rates of recurrent tumors. But there are definitely some interesting findings here that we're exploring further in a paper right now. There are significantly higher rates of post-op hydrocephalus in patients who undergo both modalities. There's been some interesting literature on the impact of radiation on post-treatment protein levels in the CSF and whether or not that is contributing to post-op hydrocephalus in these patients. But an important factor to tease out here is even within a particular patient, what is the natural course of their hydrocephalus? As you can see in this table, while patients who undergo both modalities have high rates of post-op hydrocephalus, they also have high rates of pre-op hydrocephalus. And so in particular, the factors of new onset hydrocephalus, patients who never had hydro before and then suddenly post-treatment are developing that are having are seen at a higher rate in these in patients who undergo both surgery and radiation therapy. So that's pretty much going to be the important focus of this paper is characterizing and then trying to better understand why these patients are developing that post-op. We're also looking at significant associations. So far, our analysis has yielded that preoperative fourth ventricular effacement is significantly associated with new onset hydro, which in patients, regardless of which modality they undergo. So, this is a manuscript that we're writing up now. I'm going to be presenting it as an oral presentation at NASBS in February. And then plan for publication this year. The main value is to, as post-op hydrocephalus is a significant comorbidity and can impact patients' post-op recovery, we want to better understand which patients are at risk, whether it's while they're during that initial admission for the resection, whether it's down the road as they're getting radiotherapy. So hope to better identify and treat these patients. Thank you.
Okay, thank you, Emily. On to Chi.
So good morning, everyone. My name is Chi. I'm one of the PGY3s, and today I'll be presenting research progress on my project that's conducted under the mentorship of Dr. Morgenstern. So there's a lot of already previous studies looking at the outcomes of ventricular peritoneal shunts and endoscopic third ventriculostomy in the pediatric population. But there's still a positive data looking at this among adults with hydrocephalus. So our systematic review and meta-analysis is specifically looking at the success rates and complication rates of VP shunts in comparison to ETV among adults. So we have already completed the first reviewer screen of our systematic review, where we looked at 536 citations from 3 different databases and identified 13 studies to be included in our review. Given the heterogeneity of the studies that we were including, we defined success of treatment as clinical or radiologic improvement of hydrocephalus or no further need of reoperation for hydrocephalus at follow-up. We were also extracting data looking at total complications related to the surgery, and then more finer outcomes looking at postoperative infection, postoperative hematoma, as well as the rates of reoperation. And a lot of these include the need for shunt revision, rescue VP shunt or ETV, or in some cases, patients underwent initial surgery, had a hematoma, and then had to go back for evacuation. So based on the initial extracted data, we have already performed the meta-analysis using fixed effect models, and some of the preliminary results can be seen on the right here. And this is consistent with some of the previous studies that have been seen in the pediatric population, where on the top right, you can see that the rates of success among patients who underwent VP shunt appear to be higher than those with ETV. But then we also did subgroup analysis where we looked specifically at patients who had obstructive hydrocephalus. And in those cases, we actually found that patient who underwent VP shunt actually had a higher risk of complications in comparison to those with ETV. But these are still preliminary analysis. So this is a foundation for the next steps, where we will be completing the second reviewer screen so that we can do the final data analysis. And then we'll also assess for bias of the included studies, and then complete our manuscript writing and submission to work towards getting this published this year. Thank you.
Great, thank you, Chi. Let's move on next to Noah.
Can you guys see my slides? Okay, good.
No.
No. Can you see it now?
Yeah.
So I'm in my PGY4 year, been working with Dr. Yang for the vast majority of this year, and the title of my project is Prediction of Diffuse High-Grade Glioma Survival Outcomes Using Preoperative Whole Brain Tractography Resectability Metrics. So as you all know, for adults with high-grade glioma, stent resection is a very important survival predictor. But it has some limitations. It's calculated postoperatively after you've already done a surgery. There's some variability in terms of how non-contrast enhancing portions of a high-grade glioma are handled. And there's some variability in terms of tumors that are on the spectrum in terms of size, very large tumors, very small tumors. So the question that we posed was, can automated whole brain tractography be used to predict tumor resectability and subsequently survival outcomes? So Dr. Young has a large series of high-grade glioma patients with preoperative tractography, and we queried consecutive patients over roughly a 7-year period. We looked at their tractography, and then we segmented the tumors based on overlap with functionally significant tracts. The tracts that we specifically looked at were the corticospinal tract, the arcuate fasciculus, optic, fornix, as well as deep structures like the basal ganglia and thalamus. We calculated the overlapping volumes that the tumor had with those structures, and we considered those unresectable portions of the tumor. And then we created an index, which is essentially extent of resection, but preoperatively, and it's a percentage scale resectability index to predict how much of a tumor could be resected. And what we found is that these whole brain tractography based metrics, they predict the traditional metrics like extent of resection and residual tumor volume. And then when we use Cox proportional hazard models as well as accelerated failure time models, unresectable tumor volume has a strong effect on survival outcomes for patients with high-grade glioma. I've already presented this at SNO this past fall, and so we're targeting a journal submission this winter. I also received the quantitative data a few weeks ago, and I've been going through that, so I'll probably present that for a research day in the spring.
This project. Thank you, Noah. All right, Brendan, you're next.
Okay. Good morning, everyone. I'm going to be giving a research update on a lot of the beta-gale malformation research that I've been working on with Dr. Fifi and Dr. Shigematsu this year. I've broken it up into 3 general categories of clinical outcome projects, our multi-omic analysis project, and as well as beta-gale malformation tractography. For clinical outcomes, we published on a number of projects this year. I was first author on a manuscript detailing our use of the Munchi's microcatheter.
We made a map. I'm going to show you how to win out a patient.
Paolo, we need to have you mute. Can everyone who's not
I did.
please mute?
I did it.
We also published on our use of the Scepter mini catheter at Mount Sinai, and I was the first author on that manuscript. There have been a few other manuscripts that we were able to publish specifically looking at beta-gale malformations, and then we are getting ready to publish a case report, which we're planning to submit to pediatrics on our use of chemotherapy for the treatment of dural AVF in one case. For the multi-omic analysis portion of my project, this is a trial that we're doing for our beta-gale patients where we're sequentially and temporally sequencing both peripheral and intralesional blood from vena-gale malformations, and then we're sequencing them for DNA and RNA. We've sequenced 8 patients so far, and our early results have been accepted for 2 podium talks at the International Stroke Conference, and then we had an invited manuscript, which we submitted our early results as a brief report. We are pending the additional sequencing of 32 patients for which we have all the blood samples collected for. We're just waiting for the research office and finance office to approve that purchase order and then drop off the samples. So hopefully that will be done at some point this week or next week. And then the final portion of my project would be looking at beta-gale malformation tractography. We've acquired a number of high quality scans for our pediatric patients with beta-gale malformations, and we're collaborating with the Dr. Beltrandani's lab in the Biomedical Engineering and Imaging Institute to help us refine our methods for doing tractography on these pediatric scans and trying to elucidate meaningful and significant results. So hopefully we can begin the tractography analysis at some point this winter and start getting some early results about the feasibility and looking at what how this malformation affects their tractography development over time.
Thanks, Brendan. All right, let's move to Halima next.
Good morning, everyone. Can everyone see my screen?
Yes.
So a lot of you probably already know about this project. We at Mount Sinai have a very robust population of patients who undergo meningioma resection and undergo preoperative embolization of these meningiomas. So over the past few years, we have been prospectively maintaining a database whereby we are looking at the angiographic as well as radiographic features of these meningiomas. And in the late part of last year, we published our first 2 manuscripts looking at our first series of 30 patients with angiographic features of meningiomas and 80 patients with the volumetric analysis of MRI characteristics of these meningiomas. So we have, as I said, we've been maintaining this database. So we are collecting this data ongoing, and essentially we have a series of retrospective and prospective studies that we are working on. So on the retrospective aspect, we are looking at the radiographic features on the MRIs. We're segmenting all the MRIs to quantify the pre and post-operative tumor volume, as well as something that we didn't do in our previous paper. We were looking at the tumor edema and then the extent of resection. So we are in the data collection phase of that. We have segmented around 80 patients so far, and we are working on continuing to segment further patients. From an angiographic perspective, again, we are working on classifying the tumor features as well as when we developed our angiographic embolization grade. So we are collecting that data as well. And we are essentially done with the data collection as well as the adjudication for that data. So we are moving on to data analysis phase on that part of the project. A more recent thing that we have done is to develop a collaboration with neuropathology and Dr. Umflett in particular, whereby we had been intraoperatively sending samples from the embolized and non-embolized portions of the tumor. So we now have access to the digital library of the neuropathology sites, and we are reviewing those with the help of Dr. Umflett. And I have a sample slide here whereby we can see the region that was embolized, which is more pale as compared to the region that was non-embolized, and we can see the cast. And similarly, on gross appearance, also we can see the difference between the vascular and the non-vascular, and the embolized and the non-embolized part. So we have started data collection, and we are reviewing the slides with the neuropathology team for that manuscript. And then our other goal is to also see to correlate the radiographic features with the histologic changes, and then also determine if there's an optimal timing for post-embolization resection interval. So we have all the data for that. We just have to, once we have the histologic data, we should be able to run our analysis and see if there is any correlation between the timing of surgery after the embolization. So for all of these studies, we are in the data towards the end of the data collection phase, and we should be moving on to data analysis in the next month or so. And we have also started working on a prospective study whereby we want to look at standalone embolization of brain tumors only, for which we have submitted the IRB, and we're working on a scoping review as well to see to review the studies that have been published so far on the management of meningiomas in particular that have been managed with embolization only. And then we submitted an abstract with our prelim findings for these to NASBS as well as AANS. So essentially moving on towards data analysis in the next month, and then manuscript writing on all of these projects.
This looks great. Thanks, Halima.
Mm-hmm.
Matt, you're next.
Good morning. You guys see the screen? Yeah. All right. I'll present quickly on just one project that I've been doing with Dr. Margettis, where looking at gender differences in opioid prescriptions following ACDF and cervical disc arthroplasty. This is a collaboration also with the orthopedics department. Our main research question for this project is, is there a difference between the genders in perioperative and prolonged postoperative opioid prescriptions following, single and multi-level ACDF as well as cervical disc arthroplasty using the market scan database, which the orthopedics department had and was using for quite a while, although I think Sinai is getting out of the market scan data. And so this is, we already have the results and data analyzed, and we submitted this to Spine Summit, accepted as an abstract there. And we found that female patients undergoing single level ACDF were more likely to fill a prolonged opioid prescription postoperatively. However, they overall used a lower preoperative morphine milliequivalent than male patients. And then similarly in multi-level ACDF, there was significantly lower postoperative morphine milliequivalent usage in female patients in both the perioperative and prolonged postoperative periods. The arthroplasty cohort was too small for any significant difference to be found. And so the current status is that we already have the data collected and analyzed. And so we're just working on writing up and finalizing the manuscript draft for this project.
Nice, Matt. Okay, Abby, do you want to go next?
Yes. All right. Good morning, everybody. So I'm working on a few projects this year. I'm just going to give details on one of them, and then I'll briefly mention the other ones as well. This current study is about a workflow projection for United States in neurosurgery from 2022 to 2037. This is in addition to the current project we're working on, which is about GLP agonist use and reduced pseudoarthrosis rate following a single level ACDF, which is completed and awaiting write-up and submission. The purpose was this interesting project was inspired by a study published in Ophthalmology, analyzing a future of ophthalmology workforce. And so this data used Department of Health and Human Services data, and along with HRSA and two National Center of Healthcare Workforce Analysis dashboard to obtain the future projection as well as the current demand for the neurosurgeons. Now, the reason it's important, you will see, is we used a healthcare workforce simulation model to estimate the supply and demand, especially for the reduced barrier scenario, where we're expecting the future, in the future, there will be a reduced barrier to being able to access neurosurgical care for the patients who are underserved, which would further increase the demand for neurosurgeons. So both in the status quo scenario, where the access to the healthcare remains the same, and the reduced barrier scenario, we expected a significant decrease in adequacy for the neurosurgeons by 2037 to 87% to 61%. We finished the analysis and also assessed the adequacy and regional differences, and were the status of manuscript writing. Additional studies we have published on the controversies in management of type 2 odontoid fractures, which we just published, as well as the surgical management of arachnoid web analysis at single institution experience at Mount Sinai, was also recently published, and also currently working on the pseudoarthrosis rate on an ACDF write-up.
Nice job. Thank you, Abby. Okay, Alex, getting near the end.
Good morning, everyone. We're presenting on a project that I'm currently working on with Dr. Steinberger, which is called lumbar spondylolisthesis decision-making institutional experience. Some background, it's well known amongst this community that there's a lack of consensus in the type of surgical management for low-grade spondylolisthesis. And even though this has been well described in the literature, there's a paucity on papers describing actual surgeon decision-making models for spondylolisthesis. So we set up a single institution here at Sinai, multi-departmental between neurosurgery and orthopedics, retrospective study over a 5-year period, including adult patients undergoing surgical treatment for low-grade lumbar spondylolisthesis for degenerative and isthmic etiologies. We excluded patients not undergoing surgery or patients who were operated on for non-spondy causes. We have a total of 222 patients. We collected both demographic and radiographic parameters, including spinopelvic parameters, looking at surgical outcomes, complication data to help identify root causes behind surgeon decision making for why they are doing what they're doing for patients, meaning whether they're doing decompression alone, posterior instrument fusion, with or without interbody placement. So the final results will present later this year. Thank you.
I had a question for you, Alex. I don't know if the spine section does this often, but the PED section sends out surveys of practice patterns sometimes. So it might be interesting as like a companion paper to this to have like a survey of the spine section if they would approve sending it out with like a series of cases to assess how people would decide to treat them.
I think that's a great idea. I know I've seen something like that in the past couple of years, so I'll follow up with the section to see if they have current data on that. Thanks for the tip.
Also, with Alex's help, we're also doing this study with HSS and Rush, and one other hospital are also going to be like doing like a multi-institutional collaborative, which could be super painful, as you know, with IRBs and stuff, but it actually looks like it's happening, so it's good.
Is Harel Deutsch helping you?
No. Should I be
Well, he's a Sinai grad at Rush.
Uh-huh. It's actually with the ortho. It's with the
I
ortho
see.
group. Yeah.
I see.
But
Okay.
but never hurts to get more people involved. So
Yeah.
All right, let's go to Trevor next.
Hi, good morning. Let me just make my screen here. You see my screen okay? Okay, great. Actually, let me shift my view. There we go. So I'm working with Dr. Majidi on a project looking at basal artery occlusion outcomes following thrombectomy. Prior studies initially demonstrated that basal artery thrombosis and occlusion in stroke patients did not yield any benefit with thrombectomy compared to medical management alone in these initial trials of BEST and basics. But recently, in the last year, we have trials that have come out from China demonstrating efficacy of those of that procedure in this patient population. Dr. Majidi's working group has also recently published some radiographic predictors of patients with basal artery occlusion and their experience looking at those predictors. We wanted to look at a large nationwide database sample of patients to look at outcomes related to basal artery occlusion patients undergoing thrombectomy, and then compare that to both the new positive trials in the last year and a retrospective cohort from our patients. So I wrote and have been writing code to source through the large NIS database, pulling in patients and writing scripts to analyze them for factors such as NIH stroke scale, as well as other indexes of severity of disease, and then perform statistical downstream analysis. This is obviously a large representation of a lot of things that we can generate from that. But the nice thing is that, as you see up top, to where you should focus is that in the nationwide database over 20 years, we have almost 11,000 patients that underwent thrombectomy for basal artery occlusion. So the two positive trials had anywhere from 100 to 200 patients. So this gives us a very powerful outcome. Narrowing down on some of those factors and then comparing them to our cohort here at Mount Sinai. Some of the things that we're focusing on are aspects like discharge location, predominantly in mortality in these patients undergoing thrombectomy. Our mortality rate for our patient cohort was around 27% at 90 days. The in-hospital mortality was around 28% for these patients. In-hospital for us was only 14, so we while the overall outcome of deceased patients at 90 days was comparable to the discharge for the NIS, our in-hospital mortality was decreased. And we're narrowing down on other factors and looking at outcomes in comparison to both Bausch and Attention, which are the positive trials. The things of note that we're looking at specifically are rates of ICH, which is one of the things that both of these trials indicated as a significant risk factor despite the overall functional benefit. So those are things that we're sorting out and looking at sub-analysis of these patients, both in our trial and then in comparison to the NIS and the recent RCTs.
Great. Thank you, Trevor. And last we'll have Ray.
Okay. Okay. Thank you, Dr. Morgenstern. So I'll give a quick research update on my NIH-TL1 postdoc scholarly project for this year. And my project is explainable AI post tracking in the NSICU. Okay, so we've made a lot of progress and got a lot of data and analysis done for this project. We randomly sampled a very large data set from the video EEG video source from both EMU patients and the NSICU patients. As you can see, we have over 100 patients combined, and we also have over 10,000 hours of videos that we randomly sampled. And we ran two artificial intelligence models on these patient cohorts. MMPose is an older but more well-established model, and Sapiens is actually a model that recently published by Meta AI, and it's a very powerful model that they actually pre-trained on over 2 billion images. However, from our results, the MMPose model actually performed better. We had a better receiver operating curve for the MMPose model being at 0.74 compared to the Sapiens of 0.68. And we had both higher accuracy as well as the sensitivity on the MMPose model performance. And we also had better retention for the MMPose when we filtered for high quality key point and labeling. So the MMPose was able to retain over 50% of our data as compared to the Sapiens, where it performed poorly overall, but extremely poorly on the NSICU cohort with only an 8% data retention. So I'm just gonna highlight this figure on my right-hand side. This really illustrates how MMPose compares to the Sapiens. As you can see, Sapiens actually picks up the subjects who are standing way better than subjects who are lying down, presumably because all the Instagram photos they trained on probably has relatively healthier subjects than our patients. So that's why we decided to use MMPose as the model to analyze our patients for sedation analysis. And as you can see on both for X coordinate variance and Y coordinate variance, which is a movement index that we developed, our results are highly significant. These bar plots are showing Y scale on log 10, and the p-values are to the 10 to the -11 and -18 points. So for our next steps, we're developing a machine learning model to pick up a feature importance. Our preliminary results were already seeing that the movements in the upper extremity actually drives the variance difference from the EMU patient cohort, whereas the movement index for from the head merely drives the NSICU patient cohort. These models that we just used are also out of the box, so we never did any training on our data set. We presume training will likely increase the performance by a lot for both of these models. And we're also developing a prospective trial and also talking to industry and investors who has already indicated interest in developing this eventually into a clinical technology. So yeah, this is the first computer vision study in this population, and there's a lot of potential for this project as the technology gets better both in video capturing and also AI modeling.
Great. Thank you, Ray. Raj, did you want to make any comments?
Yeah, I just, the concept for today, as Peter mentioned, was that this is an interim kind of update on the resident research that's going on in anticipation of our May, end of year research presentations. What we've all been discussing as a group is really just keeping up to date on your research and timeline. And the year goes very quickly. And, this is research, as you can see from all these talks, that is quite involved with a lot of participating components. So this type of timeline and this type of culture, I think, is very important for us. So I'm very happy with the presentations today.
I'm going to second that. It was beautiful. What we just watched was incredibly beautiful and impressive, deeply impressive. And I know you didn't even present all of your projects, although it is important to finish projects rather than to have too many. But the level of science, the creativity that you are showing is incredible. It's fantastic. And I know that you have heard me say this, but the work you're doing now is literally a foundational building block for your entire career. So I really congratulate you all for this wonderful work and thank you for presenting it.